Thank you, sir. Dr. McAneny.
Thank you, Chairman Bacchus, Ranking Members Hatch, and members of the committee. Thank you for the opportunity to participate in this important roundtable discussion. My name is Barbara McAneny, and I'm a medical oncologist practicing in New Mexico. I am here today on behalf of the American Society of Clinical Oncology, ASCO, which represents 30,000 oncologists. ASCO supports your efforts to transform the Medicare payment system to encourage high-quality, high-value care for individuals with cancer. We hope that Congress will replace the SGR, and soon. The SGR has created great instability in our practices and is eroding a very effective network of care. ASCO's vision is that of a fair and responsible system that rewards evidence-based care and recognizes that many cognitive services, including end-of-life counseling, are critical to treating patients with cancer. Any new payment system must preserve quality, enhance access to care, and first, do no harm. Quality for cancer patients involves providing accurate diagnoses, appropriate evidence-based therapy delivered safely, and a strong support system.
Have developed within their own specialty to say, these are the problems, here's how we measure them, give us the data back so we can benchmark, and they will improve.
If I might respond to that as well, because oncology for years before this came up developed the Quality Oncology Practice Initiative, which was a bunch of oncologists sitting around, what can we do, what can we measure so that we can improve what we do. This costs money for our practices to participate in, but over thousands of oncologists have already participated, willingly spending that money to do a better job. And because we can craft measures that really are pertinent to what we do every day, and when we complete one measure, then we can say, okay, everybody's got that. Let's move on to the next thing. Let's do the next step. And each of the specialties can do that to create their own quality system instead of having a broad brush generic measure.
As well as we'll be more flexible.
Need that going forward.
Doctor.
Thank you, Senator. Senator Kyle, I think one of the answers to your question about why is the care not as patient-centric as it could be is in the silos of payment, that we pay by area of the country, so that areas such as our area in the West, New Mexico and Arizona, have lower payment rates for the same service. There's differentials in the site of service, the same service in a different setting. A hospital, a physician office is paid far differently. If we had the payment more follow the patient, that would do a lot to go patient in terms of how we focus on that care. And I think breaking down some of those silos so that the money can follow where the patient is best treated will allow us to move patients from more expensive sites of service to less expensive sites of service and make that a very valuable part for health care. I'm also very concerned about the whole workforce issue. ASCO, American Society of Clinical Oncology, did a study some years ago looking at the number of oncologists that we are currently producing versus the number that we're going to need in the next decade. And about a third of cancer patients may never be able to see an oncologist because there simply aren't enough of us. So we are working hard on trying to create new teamwork methods of care so that we can get the expertise we need out to those patients, put them in the right side of service. I think the most expensive drug we give someone is one that doesn't work. We're hoping that with personalized medicine and with very good techniques of figuring out what will work on a given patient's cancer, that we'll be able to avoid a lot of those unnecessary processes that you're talking about. Doctors are really interested in doing that. It doesn't benefit us at all to go to a patient and say, I'm sorry, this didn't help.
Senator Hatch.
In my earlier life, I was a medical. Do you believe hospital acquisitions are occurring at a greater rate? And if so, what is causing the trend, and is it likely to continue? And what are the implications for the cost of care in the Medicare programs? Yes, ma'am.
Senator Hatch, I think you've hit the nail right on the head. I know that in 2010, about a quarter of oncology practices sold to the hospitals, and I think the statistics were closer to 50% of cardiology practices. Part of that, again, is the economics. Under the physician fee schedule, we're paid about 2/3 of what the same service is paid for under the hospital outpatient prospective payment system. So a hospital outpatient department can be paid significantly more for the same service. And I think that we will discover, in our workforce study, we also looked at the volume of patient care given by a hospital-employed physician versus a small business private practice physician, and it was about 60%. At a time when we have a shortage, I'm not sure we can afford that. I'm not sure we can afford to pay more for the same service in this time of escalating healthcare costs. I think we really need to look at very efficient mechanisms to rearrange how we deliver that care and go for the most cost-effective side of service.
The key question that we ask these people to come here and advise us on: are you ready to present to us as the experts a process, a methodology for payment that we could institute on January 1st with some assurance that the costs would be within a certain range to the federal government and meet the objectives that I think we all agree on here? Or, if you're not going to be ready to do that, then what would you recommend we do? Would you recommend we do an update, a positive update of 1% or 2% with some reporting requirements and phased-in pilot programs and so on during that year, so that January 1 a year later, we could make decisions about specific payment methodologies that would go across the board? In other words, respond to the chairman's question here. We're going to have to make a decision in 6 months. What do we do?
Dr. McAneny?
Thank you. Again, a very important question. I don't think any of us are prepared to answer that very quickly. This is a huge part. It's a seventh of the economy in healthcare. We're not going to be able to fix it by January 1, 2013. I think a 30% cut will put many practices and many hospitals out of business, and that will cut the amount of healthcare that's delivered. But I don't think that's the intention of any of us. So I think that, again, we're going to need another positive update. AMA data has shown that for the physician fee schedule, we're currently being paid at 2004 levels. The light bill is not at 2004 levels in my practice. I think we need some time and some stability where we can do some pilot projects, because what works, even in my practice in New Mexico, the things that work in my Gallup clinic in the heart of the Navajo Nation are not going to work in my Albuquerque clinic or in my hospital-based Silver City clinic. There are different mechanisms that will be there. The Innovation Center got thousands of people, thousands of doctors wanting to give ideas about how we knew we could save money and giving care. So we would like very much to know that we had some degree of a period of stability where we know we could count on Medicare to not pull the rug out from under our practices and from under our patients, so that we could then work with various pilot projects that can be area-specific, part of the country-specific, specialty-specific, or integrated across multiple specialties to be able to do that. I'm hoping my Innovation Center grant will prove to you that we can take a bundle of payments, take care of patients through a continuum of care, and be able to save money. But it's going to take us some time to be able to rearrange this system.
What's the problem? Dr. McAneny?
I'll tell you. If
sure
I
you will.
might give an example
Sorry?
that I can use from my own practice.
Sure.
We participated in the PQRS since it was PQRI from the beginning. I'm a fully electronic practice. We've been paperless since 2002. So I know I have data on my practice of what is done. Yet last year, we filled in all the PQRS, and I can prove that I have the documents for each one of those. Yet when I turned it into Medicare, we didn't get any of those updates. They said your data was incomplete. I said, I have my data. They said, nope, ours says you didn't do it. So and that's just one small example of some of the flaws in the Medicare system in terms of rapid turnaround for data. If we're going to manage a population of patients in the medical home We have to have real-time, very good data, where our patients are, what care they're accessing, what side of service they're doing it in, what are their complications, what are their comorbidities, who are their other doctors. We have to have that data practically real-time if we're going to be able to save the system money. But if you get data from Medicare, you get it a year and a half later when it's history. We need it now, so we really need Medicare, CMS as a partner to work with the physicians to be able to feed
So what does
data
CMS
back.
say? We don't have the money to update us.
Thank you, Senator Thune, for that question. I come from New Mexico. We're rural and frontier, so I can relate. And in the small towns where I provide oncology services, one is in the heart of the Navajo Nation, another is in the southern part of the state where the primary care doctors ask us to please provide those services because patients were electing to stay home and die rather than drive for hours to get cancer care, which is just too sad in this country. One of the things that I find is that it actually costs more to recruit doctors, nurses, physical therapists, radiology technicians, et cetera, to a rural area than it does to an urban area. In an urban area, a doctor who shows up with a spouse, both can generally find a job. In a rural area, often one can't. And we have to work harder and pay more in rural areas. Yet the Medicare system is set up with the geographic price cost indicators, which penalize those of us who have been in rural areas, who have kept costs down, so that when we try to recruit people, we're paid less for someone who costs us more. And one thing that Congress could do is to take a very strong look at the geographic price cost indicators that adjust all of our payments for these rural areas and look at whether or not they truly still reflect the cost of providing care. I'm an oncologist. If I have to have oncology nurses, I'm recruiting through a national market. I advertise nationally for people to come to Gallup, New Mexico. It's not easy, and we struggle with that. We've set up our own training programs inside the practice to train nurses, to pay them more to become oncology certified. But this is things that we're taking on. Your description of the payer mix is exactly my payer mix in Gallup, maybe not quite as good as what you described. And that practice is losing money, and I'm struggling in a private practice to keep it alive. If the payments were higher for rural and underserved areas and populations with severe health disparities to reflect the increased work it takes to take care of people who are socially disadvantaged, then you would be able to move some of the doctors and nurses and others from the more urban areas into these rural areas, and we desperately need your help with that.
Would the rest of you agree with Dr. McAneny